Well, hello and a warm welcome to everyone joining this COVID-19 conversation hosted by the Scotland-Malawi Partnership, the SNP. I hope that you're well. It's great to have you with you. All voices are of equal value in discussions, and we've lots of time allocated in the agenda for Q&A and discussion and open sharing and updates. Also, please use the chat function to register questions, and we'll pick up on as many of these as we can. You can also message other individuals directly on this call by hovering your cursor for everyone in the chat function and selecting a name from the drop-down menu. All participants are muted centrally right now, just in the interests of audibility. When invited to speak, please just unmute by clicking the microphone icon such that the red strike through diagonal disappears. We'd also ask that all videos please be kept switched off for now, just to try to keep the connection as stable as possible. But again, when speaking, please feel welcome to switch this on. If this is your first time joining us, please be reassured that these are informal meetings, taking the approach that we're all in this together. Participants in previous calls have emphasised the value of a joined-up approach between Scotland and Malawi. And so today is again all about sharing of experience in multiple directions and learning that recognises that models for one country don't necessarily suit another's makeup, demographics and culture, but that there's real value in building up a picture of our lived experience of this virus and its impacts wherever we are in Malawi, Scotland and beyond. My name's Stuart, I'm on the staff team of the Scotland-Malawi Partnership. I'll be facilitating today's call. Please don't be offended if I need to cut you short. The aim is just to include as many people's perspectives and voices as we can together. There's a real collaborative approach to these calls, where participants pool their knowledge, volunteering answers. So even if it isn't obvious to you who might be best placed to respond, I suppose I'm thinking education or agriculture, do feel welcome to put your question out there. My colleague Craig's operating all of the Zoom tech today. Gemma Conley-Smith leads on our media and comms, and do please feel encouraged to tweet or post on other social media platforms using the handles and hashtags shown. Our Chief Executive David will be listening closely for key points and actions which he'll summarise towards the close of our time together today, estimated at 90 minutes. We're conscious of the seismic political changes that have taken place in Malawi since our last meeting together on July the 1st, with Malawi being recognised regionally and globally as a beacon of democracy. I hope that we'll hear more from Malawian friends during the course of this meeting about the bearing that any new structures could have, or at the moment or in the future, on COVID-19. The SNP and MASP are politically neutral organisations. Vera Kamtikuli, known to many of you as the CEO of MASP, was not an MP nor, I believe, a card-carrying member of any political party, but was invited to take up a post in the new cabinet as Deputy Minister for Labour, which she accepted, and we congratulate Vera and wish her every success, her having done a brilliant job with MASP, from which she stood down with immediate effect. Now, turning to our first speaker, we're delighted to be joined by a senior clinician responsible for managing the care and treatment of COVID-19 patients in Malawi. Professor Jane Mallewa is Associate Professor and Head of Medicine at the College of Medicine. Professor Mallewa also has strong UK and Scottish connections, having worked and studied here. Professor Mallewa, thank you for joining us. May I now invite you to share your presentation with us.
Hi. Yes, good afternoon.
Good afternoon. We can hear you. Please go ahead.
Yes. So my principal, Dr. Mipando, is sending his apologies. He was supposed to join us today, but he was called by the Minister of Education to some urgent meeting. So he's saying his apologies. So essentially, I'm going to talk mostly on the clinical front, but I can touch also on other aspects where the College of Medicine is concerned in the COVID fight. So we have a three-prong support for the COVID fight in Malawi. You will recall that Queen Elizabeth Central Hospital is the teaching hospital for the College of Medicine. As such, nearly 90% of the clinicians or clinical people at Queen Elizabeth Central Hospital are College of Medicine physicians and surgeons. So we are actually at the forefront and frontline people against COVID at Queen Elizabeth Central Hospital. On the lab side, the college lab has been one of the main testing labs and leading in research at the moment into various tests that are out there. So that Tony Nyirenda's group have been the main focus of testing. The lab at Queen's and other labs have actually come after the college lab in terms of testing for COVID. There's also a surveillance team with the public health department at the college. So most of the surveillance that is happening in Malawi where COVID is concerned is being done by this unit. So let me remind you.
Professor Mallewa, I'm sorry to interrupt your flow.
Yes.
I wonder if you would kindly just angle your screen down a little bit so that we can see you quite clearly. We can only see the top of your head.
Absolutely. Is that better?
That's perfect. Thanks so much. Sorry again to interrupt.
I'm sitting in my car. I think that's the reason. So our first COVID case was on, or rather the first three cases were confirmed by the president on the 2nd of April. And of course, we went through a lot of initial fears and also coupled with lack of PPE to the point that at that time, most of our cases were imported, specifically from South Africa. And therefore, if a patient turned up at our hospital emergency department, the whole nursing contingent would run. And that resulted in a few deaths that were probably unnecessary because the majority of our cases that come out of South Africa actually is because they have HIV and then they have TB, and because they can't access free care in South Africa, they end up deteriorating. So the majority of those cases actually were not COVID, but people were so afraid. So we took the initiative of intensive training and reassurance of nursing teams and clinical teams. And then we did manage to somewhat allay fears, and people started seeing patients. At that time, the initial plans were that the district health office teams would be responsible for caring for COVID cases. There were some centers that were open, and we had reservations about this because the teams that were supposed to look after COVID cases were actually fairly junior members of staff, like people that were just out of their housemanship. So they were medical officers 2 years into post qualification, and we did state that with a new pandemic, there is no way some juniors should be responsible. So in the last 1 month or so, we've managed to open a specialist COVID ward at Queen Elizabeth Central Hospital, and we are successfully treating complex cases. And we are in the process of opening a second ward as the numbers are increasing. So I'll tell you what we have now in Malawi. So far, we've had, as of yesterday, we've had just over 3,700 confirmed cases. And then out of those, 103 have died. We are testing, we are getting up more than 200 new cases per day. Initially, our death rate was about 1% for some time, but in the last 3 weeks, it's jumped to 2.77%. And we think that because of the recent election on the 23rd of June, there was quite a lot of campaigning and people congregating and gathering. And I think we are seeing the result of that now. Then recently, I think we're beginning to see problems with regard to that. What we've done is to make sure that maybe we have reusable PPE, so gowns that can be washed. But even with that, as the numbers increase, we're getting into trouble now. The other major thing that we're facing at the moment is that while we're trying to open new wards, we have no nursing complement. So in the last 10 years or so, the government hasn't really been employing all the nurses that are qualifying, to the point that at the moment we are at a standstill with the ward that we wanted to open because we can't get the 19 or so or 20 nurses that we need to run shifts per day. So that's really frustrating point for us. On the point of testing, I think we've more or less run out of kits, and the testing has become very difficult and only targeted to obviously seriously sick patients. So much so that we think that probably the numbers that we're reporting are very much underestimation of what the real situation here is. Even the number of deaths that we've experienced, probably we are underestimating, because these are the ones that have been directly tested and then they die maybe a day or so later. So they are recorded. But there are deaths that are coming in at the front door of the hospital already dead. Therefore, those people are not being tested or post-mortem samples taken. And then there are some deaths on the ward that may actually be related to COVID, but because the persons didn't get tested. So we are facing that problem, even though there's been upscaling of PCR testing, even to district level. But I think it's the kits that that are a problem at the moment. So we probably are not seeing the true picture. I think we're also beginning to see increasing psychological impact of COVID on the frontline workers. Our medical registrars are now beginning to say that the stress of having to see death and patients very sick from COVID it appears to be impinging upon their psychological well-being. We do have a psychiatry department at the College of Medicine, but we have very few psychologists, as it were. So for the college, we are trying our best at every point to make, to make a difference and to help. For instance, because we know that the number of beds that we need at the hospitals compared with the number of patients that we're going to face, we nowhere near going to cope. So the college, through myself and my colleagues, we are just about finalizing opening a COVID treatment unit at the main campus to sort of like take off the pressure from the government or the Ministry of Health side. I think that's what I can say. I can elaborate if on any point if people have questions.
Thanks very much, Professor Mallewa. That's very useful and illuminating indeed. I wonder if you've had any encouragement from the Ministry of Health or the Presidential Task Force regarding additional resources that are needed. Yes,
the Presidential Task Force is sort of like the apex of the coordination process. And on the point of PPE, yes, we have had a lot of that come through from the ministry side. But then we also have organizations that have, pulled their weight to try to help with the COVID fight. So for instance, the research affiliates of the College of Medicine, particularly the Mallewa Liverpool Wellcome Trust. So they've been responsible for bringing in an oxygen plant. So that came fairly as an emergency, so much so that our COVID wards now have piped oxygen, which makes life much, much easier for us. If we were to rely on cylinders, then we probably wouldn't have coped. So they brought in oxygen. We've had charities that we run within our departments that have actually been responsible for actually making the usable PPE. So all the gowns that we have, all the scrubs that we have been made by either Wellcome Trust, our departmental charities like what we call the Chira Fund. So we've made those things and we've made hundreds and hundreds of sets so that at least we can rewash them and reuse them. We've had other research affiliates like Johns Hopkins Project. They've also, done a lot of work in bringing in PPE and various other supplies. So yeah, so I think it can't just be the ministry side. I think everyone and every organization that can help, we are all actually working all together. Yeah.
Thank you. You mentioned oxygen, and Professor Paul Garside at Glasgow asks if oxygen production facilities in Blantyre are there, and if this is able to be brought into Lilongwe, and has that happened?
I'm not so sure that I have the information from Lilongwe. But off the top of my head, Lilongwe tends to be a better equipped hospital than Elizabeth Central Hospital. Okay. I have a feeling that they probably do have oxygen. We haven't heard anything else. So, to the contrary, that is. So, the oxygen plant at Queen Elizabeth Central Hospital is actually adequate enough to supply the whole hospital. But it's just that the piping system has for the moment has just been the initial COVID ward that we planned was wired up and it has about 14 beds. But then we had a second ward that was our TB ward and it has 40 beds. The only problem with the second option was that it took us time to convince the hospital authorities and the Ministry of Health to actually open this second ward. because the feeling was that the big hospitals could not be COVID hospitals because of the infection risk to everyone. They tend to be fully, you know, there is, we are full capacity most of the time, and the traffic from ordinary people into those hospitals is so big. So it took us time to convince the hospital authorities that we had no choice. So the only problem, we do have the oxygen, but we don't have the nurses. So we haven't opened the ward, the second ward, despite the fact that we are set. It's just that we don't have the nurses. Yeah.
Understood. Dr. Barry Klassen, who I'm sure you know at NHS Tayside, has a question. He says, thank you, Jane, for your candid update on how you're responding to COVID. Have you had support for your limited resources, including human resource? And certainly you've mentioned the issue with nurses there.
So, like on the point of the College of Medicine, we've convinced them to temporarily employ some nurses so that they can man the third unit that we setting up at the college. On the hospital side, there has been some move to employ people urgently. And they have some new nurses, but it's not adequate because each of those units is requiring no less than 20 nurses in order to fully man the shifts. So far we managed to get the 20 that are manning the initial COVID ward we opened, but this second ward, so far we've managed only 6. And the problem is, probably the same people that we're talking about that are being shifted to the COVID wards are coming from the general wards, which means that those general wards, they are going to suffer because normally we have something like 60 plus patients per ward, and there might be one qualified nurse per shift. So it becomes incredibly difficult, but the nurses are out there, but they just haven't been employed. Someone needs to maybe temporarily give them contracts, even if it's for 6 months until we see where this is heading. So, yeah. That's what I can say.
It's Barry Klassen here, Jane. Hello.
Yeah.
Thanks for that answer. One of the things that we did in Scotland early on was to fast track some of the final year nursing students and whatever, so that they could go and work in the ordinary settings to allow some nurses from the general wards to then go to the COVID areas. I don't know if you'd considered that as a model.
For us, fast tracking any of those groups like nurses or even medical students, it hasn't happened. The thing is, we already have qualified doctors and nurses that haven't actually been employed.
Yeah.
In the past, I can tell you, in the past, something like 10 years, the contingent that qualifies every year, not all of them get to be employed by the ministry because they've got limited maybe capacity to employ with the current situation, financial situation. With the new government, it looks like they're serious about making sure that they close all loopholes for money disappearing. So hopefully things will improve. But as of now, there are people out there that can't be employed within a day or so, that are out of jobs or they haven't ever been employed. Yeah. So we somewhat we need to get that group. We don't even need to just fast track nursing students or medical students. We actually have qualified people. Yeah.
Thanks for that.
Thank you. Mary Popple from Just Trading Scotland, would you like to come in with your question, please, Mary?
Hi there. Yes, hello. Thank you very much for that update. I think what you said about testing kits is a real worry as well. You know, lack of nursing, lack of testing kits. right across the country. Are there any plans to bring some more into the country, or is that a lack of resources? And then, because I work with people in northern Malawi, I'm interested in testing occurring in the north. Perhaps you could elaborate on that. Thank you.
I think it's the question that we run out of testing kits, and maybe we're not really going to have them very soon. Yeah, the capacity to test, like the PCR capable labs, actually has increased, including in the north. Yeah, Zuzu was one of the first centers in the north, and then I think there's been more districts. So the issue is about this capacity to actually bring in those kits. And I think the last conversation I had on the COVID committees was that there were about 1,000 kits that had come, and that these are the ones that we are now having to ration to seriously sick patients. I see that I've got some colleagues on this talk that appear to know more. They might have come from the lab side. Maybe they know better than I do as to what the plans are to bring in more of these kits. I think I saw someone making a comment. I don't know whether they can come in. But that's essentially where we are. That the last I know was that there were about maybe 1,000 or so, and they were being earmarked for those very sick patients, in particular in the central hospitals.
Thank you. Thanks.
I think Yona, I think has something to say.
Yes, Dr. Yona Matemba, the University of West of Scotland, has a question about the Presidential Task Force. Now, Professor Mallewa, I understand that, and please correct me, I understand that it has been changed a little bit with the new president in place, but that Dr. John Fuka, who took part in our last meeting at the beginning of July, remains a co-chair together with the new Minister of Health. Is that right?
That's correct. Yes.
Okay. Yona, would you like to come in with your question, please?
Yes. Thank you so much, Dr. Mallewa. Besides the questions that I've put on the chat, I've got another question in addition to that, which I think probably is penitent and worrisome. I hear reports in Malawi that some people, especially in Indirande and other sort of areas, when they see ambulances and they see medical personnel coming to collect COVID patients who are wearing PPI kind of kits, they are being chased away. In some cases, one of the ambulances was about to set on fire. Now, my question is, on the ground, what's happening to sensitize and educate Malawians of what COVID is and how it actually looks like? Because without these PPEs and without health personnel wearing these PPEs, they are at risk themselves. I'm just really worried about this. I just heard this week and it really got me worried.
Thank you, Yona. It did happen at the very beginning when we had the very few first deaths. What happened was there were original plans to have burial teams that the locals wouldn't bury their dead. So these teams would indeed arrive in full PPE. And the other thing you might recall, Yona and James now, is that in Malawi, traditionally, women do not bury bodies. So the burial teams had females, and that caused such a hoo-ha. And I think those initial teams were indeed stoned and chased away. And also then testing teams would indeed arrive in full PPE in places, particularly for contact tracing. And that did cause a problem in some areas, but that would have been around April. And then since then, there have been more messages, particularly on TV and on radio, and quite a lot of people in Malawi do have the local radio station capacity to receive those radio stations. So there's been more messages, and there've been messages in various other fora, like social media and so on and so forth. So there is still a lot of misconception, and we've had to change how we carry on now, because now the bodies, particularly the bodies that die in hospital, are decontaminated in the hospital and then sealed in body bags before being released to the families. So now there are no longer burial teams going to areas like Ndirande and everywhere. Instead, bodies are decontaminated at the hospitals and sealed in body bags before release. As for surveillance teams now, I think they've changed as well. They're not going into houses anymore. If they get contact numbers, then they call those people and arrange that the testing be done centrally. So, but then if you, I don't know whether you've seen pictures from Malawi lately, quite a lot of people are wearing masks. Yeah. So people are cottoning on what this is. There's a lot of misconceptions, but people appear now to be moving on and realizing that this is for real. So there are a lot of people wearing masks now. So we're changing, I think. And then as various committees, we've decided that we're going to, each department, each area, you know, like public health, as clinicians and marketing people, we want to have messages that we put out on TV, on radio, and various social realms in order to, you know, to talk about everything, including nutrition. What should people be eating, you know, to try to maybe get themselves stronger? What should be vitamin C foods? What should be vitamin A foods? Things like that. So we're going to start doing that now in order to reach more people.
Thank you very much.
Thank you. Rosie Woods, I recognize you say that you're having some technology difficulties there, but if you can hear us, would you like to come in with your question, please, for Professor Mallewa?
Hi, yeah, thank you very much. I was cut off a little bit at some point, so maybe you mentioned it already, and I'm sorry, I'm going backwards a bit as well to just the point you were making about not having enough nurses or personnel. So I was just wondering if you'd picked up on the fact that there's quite a lot of retired nurses. I know that we were aware of some groups in the north of retired nurses who could maybe be reactivated, for example.
Retired nurses?
Yeah.
Hello?
Hi, yeah, there are retired nurses anyway in the north that we're aware of, but they were kind of retired earlier. So I know that they could potentially be reactivated to be supportive on this, on the front of personnel.
We are discouraging getting older people on the front line because they're not doing very well here when they get COVID. So for instance, even medics, those doctors that are maybe above 60 years of age, we are not getting them to be on the front line. I would discourage getting older nurses to be on the front line because once they get sick, then the prospects are not very good, particularly because the older the person is, the more chances that they have comorbidities. So people with diabetes are doing very badly here. People with HIV and then they're older, they're not doing very well either. I would go, if I was to go for any extra pairs of hands, I would go for the young nurses that are out there that haven't been employed, and we should just put out an advert if we can get the funding.
Great, yeah, thanks. I think I was under the impression that these were retired quite early, but I'm not sure how that was possible, but yeah, the full information.
The retirement age in government is 60 years. Yeah.
Okay. Thank you.
Thank you. Professor Paul Garside had a question asking Professor Mallewa whether you could please make the details of the hospital fund that you mentioned available so that people can contribute to that if they wish to. That's perhaps something that we can follow up afterwards and send details to participants and also put on our web pages. That would be great.
Yeah. What I can say to you is that it's called the Chira Fund, and we have a UK arm. So people can actually donate to our UK arm, and then they send the money to us. Yeah.
Super, great. Well,
so
I'll
send you the details.
Super, that's great. Shupo Kumwenda, would you like to come in with your question?
Okay. Aro, do you hear me?
Yes, thank you. Go ahead.
Okay. My comment was as she was saying that most of the people are getting messages on COVID-19, but to us, as we are working in our community, I've seen that we are so far because there are many people in the villages that don't know more about COVID-19. And the only thing is what I've seen in the villages, they don't have videos, they don't have computers, they don't have phones. So the government should take a serious measures so that the people in the villages should know more on COVID-19. As I'm talking today, we had a massive campaign whereby we were giving masks to the hospital at Ekwendeni and soap with our colleagues. And we went also through to the village where we find some problems there because they don't know how also to wear mask, and the clinician and the nurses are the ones who were teaching them how to wear mask. So we need to have serious measures on how to reach people in the villages. And we just thank the Smile Malawi, the Banana Box, Abba Ed, and Raven Trust for the support which they gave us this week. And we are targeting more than 10,000 people to have a mask. So we need government also to take serious measures on COVID-19. Thank you. I've got Lydia just nearby. So.
Thank you very much, Shupo. There's a related question, I think, from Willan Kalinda. Willan, would you like to come in?
Yes, I was trying to say that the government, we are all looking at the government because as community members, we don't have access to testing kits, but also we don't have that ability to have strong financial muscles to go into the communities to disseminate information. So as Shupo has said, it is true that in the villages, in communities, people are not having the full information about this COVID-19. They know about the disease, but then on how to prevent the spread and getting of the disease is a problem. Now, we would like to ask the government once more that in rural areas, people really need to have the information. We have seen people going around towns with PA systems, making the announcements, advertising or telling people of what COVID-19 is all about, and then telling them on how they can protect themselves, as well as protecting themselves from getting and spreading. But then if we go into the typical villages, you find that this information is not there. Therefore, it is my request that the government should prioritize to go into the villages rather than just being in town. In town, people, they do have phones. People, they do have TVs. They do have computers. They have got an access to internet where this information can be easily accessed. But this is not the case in the villages. So the villages should be first priority to the government at this time. That was to be my question and suggestion to the government. Thank you.
Well, and thank you for that. As we've discussed before, I think one of the aims of these meetings is to be able to share from wherever we are all around Malawi and Scotland and elsewhere what the situation is for us. So it's really valuable to hear that. I'm very grateful to Professor Mallewa for joining us, who's not a politician. Professor Mallewa, you're a senior clinician. So we fully take account of that, but how would you respond to what you've heard there, please?
So my understanding is that the way I say it is that everything can't be government alone. Yeah, I will tell you that the initial PPE that we sourced wasn't via the government. We realized something was coming our way, and we went out, used our charities and various organizations to give us the initial PPE until we got things from the government. I've always said that, and this I believe is true, is that it's not, if we wait for government to do everything, then nothing was going to happen in a hurry. And I believe that the initial messages have actually been gone through the churches. Yeah. So I know that even the Catholic Church, as a huge institution, did go out with messages to its population, even to the village level. So we have to utilize institutions that are already in place that actually operate at the village level. That includes the churches and various NGOs even, yeah. We need to take those messages to the locals. Who is government? Government is ourselves, to be honest with you. So we need to make sure that that happens. And we can only do that if we take responsibility. If we've taken a degree of responsibility at the hospital levels to know that this is coming and this is upon us, and therefore we have to do something about it. And we've done so. So I know that churches have been out there putting messages out. I know that various NGOs and community groups have gone out there to have those messages put across. But I also probably disagree to a certain extent that phones are only in towns. I don't think so. Most people at village level, there'll be one or two, even in a household, that will have a phone. You'll be amazed how many very poor people that end up in our wards, absolutely very few things, but they have a phone in their hands. So we can't send messages through those phones. And our telephone providers like Airtel and TNM are sending out such messages via those phones. So even at the village level, if you have one or two people that have a phone, that message can go across to them. There are messages all the time on the phones that say stay at home unless if you know you have to go to the market to buy food, but otherwise stay at home. Yeah, and then now those messages are evolving that people should wear masks. Yeah, and the other thing as well, maybe our NGOs that are working within the village level and the churches could be encouraged to actually make those demonstrations in church. But we're discouraging church gatherings, but somewhat can those people, those institutions also be utilized to make those demonstrations maybe outside rather than inside the church, yeah? And then quite a lot of the times, the masks are being made to look like very complex things. These cloth masks are not complex things. Therefore, NGOs and churches should be encouraged to show people how to make a mask. Because if we can't employ nurses, then how do we have the money to actually give everybody a mask? Somewhat, some of this responsibility ought to be shifted to stakeholders. Was it Yona that works in the village, or was it Yona or Willa?
Shupo and Willa.
I mean, what kind of work do you do? Because maybe I need to understand what you do. Because then you could actually take responsibility to, to see how we can rope in the churches and various community groups to help. That's what my feeling would be. But waiting that everything should trickle down from central government, it's going to take months, and this thing is upon us, and we need to do something ourselves as well.
I don't want to speak for people, but just in the interests of time, fully hearing your points there, Professor Mallewa, I think from what I understand, both Shupo and Willan are very active community representatives, very much involved and very keen to support, and have been doing lots of good work. So I think that thistle has been grasped. Just a couple of brief points on the chat. Dr. Tracy Morse says that there are efforts being made to train and work with HSAs to share information in communities, and we'll provide more on that. Barry Klassen, WHO and International Federation of Red Crescent of Education Materials and Public Health Aspects of COVID. These are things that we'll be very happy to signpost to on our COVID-19 web pages, and for members to share with partners. Agnes supporting what Will and Ashupo said, a need for civic education in rural areas. Brian, I'll come back to your question as a last one, if we may. Heather Palmer speaks about the progress being made wearing masks, but the problem being about testing and whether there are plans for more testing in rural areas. Professor Mallewa, maybe you would touch on that, recognizing what you said about the absence of kits, and also just taking Bryony's question as a final one, if we may, for now, before turning to Professor Mandala. Really, your thoughts about the future, what you expect in terms of incidents coming up.
So I will start with the testing in the villages. So essentially, the directive we've had now is that we're not going to test everybody, that we're going to test people that are obviously symptomatic. But those that don't have symptoms, therefore, if they don't complain, they won't be tested. And also that for those that actually get sick with COVID, their contacts will self-quarantine, let's say for 14 days, yeah. But by day 10, if they do not develop symptoms, they are not to be tested. So they will be tested only if they develop symptoms. So as of now, that's the directive that we've had. As such, because the situation changes each time, so it is possible that this might change, because we get directives as things change. It might change. Yeah. And then what was the second question?
It was your thoughts about the future, looking to what you anticipate there being in terms of incidence of COVID-19 in the times to come.
It's going to escalate badly. At the moment, the numbers have just are on a steep rise since about 3 to 4 weeks ago. We believe that's because of the gatherings that we were having for election, around the election time. So because that has probably spread the virus to the point that now we're going to see, we haven't plateaued yet. We're nowhere near plateauing. And I think things will simply get out of hand. And at the moment, it looks like our health system is not going to cope. Yeah.
Well, thank you. No, please go ahead.
I'm just saying that probably we're going to be on a stiff upward curve for at least a year. Yeah.
Well, thank you very much for sharing so openly the situation. We appreciate it's an extremely important frontline role that you're involved in with, as you describe it, very limited resources. I know that you've very strong partners in Scotland and elsewhere. You've mentioned a number of the international funds and collaboration, so we'll keep very much in touch. Recognizing how busy you are, if you need to leave the call and continue with your responsibilities, please, of course, feel welcome to do that, but equally to stay for as much of this meeting as you can and you would like to. But thank you very much from all of us.
Thank you. Thank you so much.
Thank you. Turning now to Professor Wilson Mandala. who's Dean at the Malawi University of Science and Technology. Wilson, over to you. Very welcome.
Thank you so much, Stuart. It is well, it's an honor to be joining the meeting today. Maybe I would start with the final statement that Jen made, which is that the trend will probably continue to get worse until much later on in the year or even early next year. So a couple of things that I want to point out, more or less building on what Jen has ably articulated in her presentation. If you recall, last time we had this meeting, Dr. John Puka, who is the co-chair of the Presidential Task Force, presented on the scenario as it was back then. And if you remember, he had a couple of graphs that he showed, and he also had some more or less estimates as to where we will be by this time and where we will be. And I did ask a question of as to, what would be the state beyond winter. So worth mentioning that this is our winter, and people already were talking that winter will hit us hard in terms of COVID-19 cases, just like had been the cases in other countries, especially in the West. And we are realizing that. So a couple points that I just need to put forward. Number one, we unfortunately had the COVID-19 pandemic coinciding with the elections. And during the campaign period, and again, this was highlighted by Dr. John Puka last time, during the campaign period, there was no social distancing and all that. And we did expect this to happen. So there's been a drastic increase. All right, somebody wants to see my face. All right. All right, there we are. I'm home, so don't mind how I'm looking like. So we did expect this picture at that time because there was no social distancing. There were no people wearing face masks during the campaign rallies and all that. So that was expected. That's the first point. The second thing was that the previous government, just when we had our first cases, I think in early April, immediately declared a lockdown of some kind. And at that time, people went into the streets and all that. Reason being that, the economy of Malawi is such that people essentially rely on, hand to mouth on a daily basis. So they earn some money, get some food and eat. So if you have a lockdown, what it implies is that those who are heavily underprivileged will not have the ability to go out, get some money, buy some food and then go home. So there were some strikes against that. And then one of the human rights bodies took the matter to court, and there was an injunction that was put in place. That injunction has been in place since then, and I think there was a hearing yesterday on the same matter. I haven't heard the outcome yet, but chances are people will now start looking at the picture that we now have on the ground, and I think common sense will prevail. Because if ever we needed a lockdown, this is the time to have a lockdown. Building on what Jen just mentioned, the numbers are alarming. We are well over 3,000. At that time when the lockdown was initially suggested or proposed, we only had a couple of, I think we only had 12 cases or so. Or second point. The third point is, for some reason, we still are importing, we are getting the returnees from South Africa. As you might be aware, South Africa is now in position number 5 worldwide in terms of cases. The chances are all those Malawians who are returning to Malawi now, the probability is high that quite a number of them are already COVID-19 positive, or they're asymptomatic in transit. By the time they get to Malawi, then they start showing symptoms. As with previous experiences, when those returnees get to Malawi, there's very little tracking that is put in place. So they would just escape, going to communities. Some of them, they haven't seen their families for a year or more. And as they return, they go back home, maybe innocently, without knowing, naively, and they end up, passing on the infection to those in their households, in the communities. That's the third point. The fourth point is the issue that Jane raised, i.e. limited number of testing kits. We ran out of testing kits, and I think during the last meeting, Dr. Puka did mention that the testing kits were running out. Well, they did run out. There have been some, I think there was a number mentioned of about 36,000 that have been brought into the country. Again, 36,000, if you spread them out into all the testing centers, that's nothing. And as Jen was saying earlier on, even in Blantyre at the moment, we are not able to test as many people as we would like to because the kits are not there. Those that are there are being used to test individuals who are way advanced with the infection, that even though you come up with a positive result, it might be too late to save that life. A case in mind is our own university registrar who passed on last week, and we buried him on Friday. He ended up testing positive on a Wednesday, and the same Wednesday he passed on. So, those 4 points are crucial. And number 5, sorry, there was number 5. There had to be number 5. Number 5 is the issue of nurses. For some reason, and I think the reason is because of the transition in government, the previous government did not prioritize recruitment of nurses or other hospital personnel. Jen mentioned this as well, as has been the practice previously. You'd have a class that is graduating already committed, already offered a job in the previous years. In other words, they didn't have to stay home. They'll be taken on board and they'll straight away go into various hospitals and health centers throughout the country. For some reason, again, I think, and I'm guessing here, it was due to the transition. That hasn't been the case. I think during the previous year and the year before that, we haven't been recruiting nurses in high numbers. That now is coming back to haunt us badly because we now have a crisis on our hands in our hospitals and we do not have the personnel. This is ending up having in the few nurses that are there doing shifts back to back. And it's not healthy for them. They are tired in some cases. There's a friend I have on Twitter who said she had to stay on after one shift, then she goes on to the next shift because whoever was supposed to take over from her is not able to do so. That, in my opinion, is a huge problem. And now this is what is being observed at Queen's. Now, Queen's is like an exemplar hospital in Malawi. This is like, the main hospital in Malawi. Now, if this is what we are saying at Queen's, one wonders what is happening elsewhere, especially in the district hospitals. So those are the 5 points I thought I should bring forward, because if ever there is need for help for Malawi, it has to come into those 5 areas, I feel, especially the kids. The nurses, if we do get them, then we also have to provide them with appropriate PPE so that they can work safely. There was a time when the few nurses that are there were not being paid appropriately for working long hours. But I think that issue has now been resolved. But Jen, if she's still online, may want to also comment on that. So instead of me saying more about what MAST is doing, in response to COVID-19 in terms of innovation, I thought maybe we could spend some time discuss those. And if members still want to know what we're doing in terms of innovations, I can always come back to that. But I've seen a few questions or a few hands been raised with questions. Maybe we could go into those and then, Stuart, I don't know what you think. Thanks.
Wilson, many thanks indeed, and condolences on the passing of your own university's registrar. Thank you for these valuable reflections. We're running slightly behind, but as ever, really valuable input from everybody, and important to take time to have the Q&A and the discussion. I wonder if anybody would like to take up Professor Mandala's invitation there to ask questions or make comment on any of these 5 key points that he has picked out.
I would like to comment.
Please do.
I agree there was an injunction regarding lockdown, and I don't think it's practical, as he said, and I don't think we ought to be chasing a lockdown, because there are people that have to make a living on a daily basis. And I think the government, we don't have social security systems here, so there is no money from anywhere other than whatever a person makes, and there are very few people that have savings of any form. So my plea is that NGOs, churches, we should encourage people to wear masks, and as much as possible get people to make their own masks from some old cloth or something. That might help. Yes, we are in the middle of winter, and we think indeed that the whole spread was started at the point of the gatherings that we had around the election time. But then, so we've got so much community spread. And of course, winters are cold in Malawi, but people are not always indoors. We still have mildish winters here. So I think it's just going to escalate, even if the winter goes away. It's just because of the numbers. And I don't think now it matters whether people are coming from South Africa or not. There is that degree of community spread. It doesn't matter anymore. And I think most of them have been repatriated from South Africa already. We had this at the very beginning of the pandemic when they came out from South Africa. So that would be my comment, that from now on, our issue is really get everybody into a mask when they're going out into the public. A lockdown, it will kill people because they will go hungry. Thank you.
Thank you. Dr. Yona Matemba.
Yeah, thank you, Dr. Mandala. Thank you very much for articulating those 5 points. And I'll go back slightly to also what Dr. Mallewa had said. I've got a broader question probably to ask. I noticed that in most of your comments and sharing with us your views, I think what's lacking here is government commitment, or at least public government commitment, in terms of a master plan of how the government of Malawi, I'm talking about the new government now, how is going to address this in terms of what kind of budget does it have, or it wants to have, to make sure that all these things that you are suggesting, or I think ideas that people have, will be facilitated. My fear is that there is a lack of government front-facing on what's happening in Malawi. Now we have a new government, and I wondered, Dr. Mallewa and both Dr. Mandala as well, whether you can be influential in some way to encourage the government to have a front-facing kind of profile, so that it can begin to explain to Malawians exactly what is going on and what the government at a policy level is doing. Thank you.
Thank you so much for that comment, a very valid comment indeed. So, as I mentioned at the beginning, the new government just came in, so the elections were on the 23rd, as you are all aware, and they've just been in their positions for a few weeks now. There's a new Minister of Earth. I think they are all still trying to get things moving. You asked a question about what budget will be required to respond to the current situation. I haven't seen any. You make a point as to whether either me or Jane or anybody in academia would, influence the government to come up with a solution to, or to come up with some proposals to the way forward. This is why Dr. John Puka is a co-chair. The whole point was that to have a mixture of technocrats as well as academicians in that presidential task force, who will then make evidence-based decisions and also come up with evidence-based solutions as to the way forward. And I must admit, since John came on board, there's been some sanity in that task force, and a lot of things have changed since then. What has not changed, though, is going back to exactly what you said. I had been expecting a response of some kind since the new government came in. We kept on saying, so when they came in, the first ministers that were announced, the first list only had Minister of Finance and a couple of others. There was no Minister of Health at that stage. And everybody was saying, no. The priority should actually be choose a Minister of Health right now, who can then start providing some leadership in how we respond to this pandemic. I'm glad to say that since then we do have a Minister of Health. And the sad thing, well, maybe not so sad, but the then Secretary of Health has been taken out of the position. So we're hoping that eventually there will be a new Secretary of Health. But at the moment, I think Dr. Charles Masambo, whom Professor Paul Garside knows very well, is now, I think, acting in that position, and Jen may want to correct me on that as well. But I feel that in the coming days, the Presidential Task Force, together with the ministry, will come up with a strategic plan on how to address this. And that will be accompanied by a detailed budget, so that when they start talking and seeking help from outside, they will present both a plan as well as an estimated budget of how much support that is required. And as Jane has already said, the way forward now is actually to prepare for the worst possible scenario and for people to protect themselves, i.e. wear masks, as well as to social distancing. And you know, adding to that will be the required or the recruitment of those additional nurses who are urgently needed now, maybe even yesterday. Thank you very much. I hope I've answered your question, though.
Thank you so much, Professor Mandala.
Yes.
Agreement amplification there from Dr. Matamba, saying he too is waiting for a strategic plan, including a budget. We've been fortunate in this series of COVID-19 meetings, as you know, to have had participation from both Dr. Charles Mwansambo and Dr. John Puka, and we certainly will put a polite request to the Presidential Task Force for them to participate in a future meeting. But we're delighted with the speakers who've participated today to hear firsthand from you all. So thank you very much indeed, Professor Mandala, for joining us there. As before, very welcome to stay for as much as you can, but realise if you need to head off. I'd like to turn now to Professor Heather Cubie, who is the chair of the Scotland-Malawi Partnership, as you know, but a distinguished scientist in her own right, and one of the grant holders, co-grant holder of a Scottish government-funded project in Malawi on cervical cancer screening. And I think something of a good news story during these difficult COVID-19 times. Professor Cubie, may I hand over to you, please?
Yes, thank you, Stuart. And may I say it has been salutary to listen to these last few talks and to know how things are escalating in Malawi. While we're very sad to hear that, I guess it is the pattern that has been happening in most places. And indeed, I would also like to congratulate Malawi in having put it off for several months, because that period, April to June, when we thought your escalation would be higher, has been delayed until after your election. And I do hope that all that has been said today can lead to help coming in the right way. But do let me share this good news story of the first quarter of, well, the first 3 months, let's say, the April to June part. As Stuart said, I and my colleague, Dr. Christine Campbell, lead a programme of cervical screening and treatment called MalScot. It happens in 7 hubs with their associated health centres across all 3 regions of Malawi. And we've received many images of the progress during April to June, despite COVID, which show good hand hygiene, protection for providers, social distancing in rural areas, because our project is happening in rural areas. Now, if I can manage to screen share, I can bring up just a couple of slides, I hope. Well, I'm trying. No, that's, does that work? Do you see a slide?
Not yet, Heather. I'm sure you're hitting the green share screen button. Which
I am hitting the screen share button.
Unfortunately, the level of my technical backup here.
Well, it doesn't really matter. But anyway, I wanted to show you actually the sort of conditions that have been operating in our rural places. The hand washing stations, but in particular because there's been talk about the rural areas not getting the messages and not perhaps social distancing. That especially was what I wanted to show, because in cervical screening there is always a health talk at the beginning, and of course our team have over these last few months included in their talk about the importance of cervical screening, also the importance of precautions against COVID. So these rural populations have been hearing messages very directly. Now, of course, the numbers have fallen that have gone to the health centres, even during April to June. But actually, the teams in each of the hubs have been very innovative and have taken their services to women in increased numbers of outreach visits. And it's those outreach visits that I think we should all be very proud of, because between April and June, actually nearly 5,000 women were screened. And there were 106 of those received immediate treatment, and a further 34 suspect cancers were put on the relevant pathway for them. So that means 140 women during this period have had clinical management of their cervical disease and cancer, and it's been mitigated during COVID. Actually, that's something we haven't achieved in the UK because we suspended our screening programme. And our colleagues in Malawi have felt, up until now at the very least, that it was too important to deal with the high numbers of cervical cancer cases to suspend screening. So our national coordinator, Beatrice Kubota, who is on this call at the moment, asked me to acknowledge several things when I spoke. First of all, the dedication and enthusiasm of the providers in all of our centres, despite the risks from COVID. And together with that, the funding, the extra funding, so that we could help provide additional PPE for when there was a shortage of government supplies. And that has been a mixture of buying extra, but also of making locally. But they've also appreciated the ongoing funding, which has allowed them to continue with the programme in relation to setting up new health centres to create actually a good environment for both the providers and the clients, even though new centres have not started screening, but they're ready to do so when they can. So I do hope that this escalation in numbers doesn't actually mean that will be held back even further. Beatrice also commented that the Scottish Government requirement for monthly reporting of the pandemic had been helpful. And indeed, it had helped the hubs to track the impact and mitigate where necessary. And so I'd like to say that actually between us, what we could provide from Scotland, but what a dedicated and willing staff have done locally has made a difference to quite a lot of women. Thank you.
Thank you, Heather. That is indeed a very, very heartening story, and congratulations to you, to Dr. Christine Campbell, to Beatrice Kubota, and all of your colleagues. I'd like to introduce Lillian Nseula, who is going to speak to us about fuel poverty arising from COVID-19 and innovation around that. Lillian has been a master's student at the University of Strathclyde and is back in Malawi now. Lillian, are you with us and happy to present, please?
I am indeed. Thanks, Stuart, for that. As mentioned earlier, my name is Lillian Nseula, and I am an energy expert and a member of the Scotland-Malawi partnership. Today, I will be presenting to you the Kupika kwa Pweka cook stove. For those of you who don't understand the term Kupika kwa Pweka, it simply means cooking made simple. This stove is specifically designed for low-income households and is made from old recycled cariums and scrap materials. If you take a look at Malawi's energy mix, biomass is the most used energy source of fuel in most households, accounting to 84%, followed by electricity, which is 15%, and 1% for LPG and gas. Since the start of the pandemic, fuel prices have significantly gone up, with those that have been disproportionately affected being the poor and marginalized households. As a result, they have resolved in using agricultural waste, which not only exposes them to household air pollution and are likely to have the worst outcome if exposed to the coronavirus. Because of the roles that women and the girl child play in most households, the pandemic has exacerbated their situation and made it worse for them because they need to go and procure fuel wood for cooking and heating. I would also want to make a point across to you that among other benefits that come along with using the Kupika kwa Pweka cook stove are that it is durable, safe, and energy efficient. It is made from 100% recycled materials. It can be fueled by biogas or LPG, which are both clean and affordable. And it only costs £15, which is 40% less than other imported cook stoves. Additionally, the cook stove will help address the following United Nations Sustainable Development Goals, which are goal number 3, good health and well-being, goal number 5, which is gender equality, goal number 7, affordable and clean energy, goal number 9, which is industry, innovation, and infrastructure, goal number 10, which is reduced inequalities, goal 11, sustainable cities and communities, goal 12, responsible consumption and production. Lastly, goal number 13, which is climate action. I thank you all for your attention and your joint effort in supporting families and communities recover better during these challenging and unprecedented times. Thank you very much for that.
Lillian, thank you very much for that. I wonder if you'd be happy to put your email address or a contact in the chat function. Absolutely no pressure to people can contact you through us if you would prefer to do that. But if anybody in the meeting would like to find out more about Lillian's work, then do please just contact any member of staff at the Scotland-Malawi Partnership.
Thank you. I'll be delighted to do that.
Super, Lillian. Thank you. Staying on responding to COVID challenges, I'd like to introduce Alexious Kamangila from the charity Reprieve, who has a very clear message on a human rights aspect arising from COVID-19. Alexious, you're very welcome.
Thank you so much, and thank you for the opportunity to contribute. And quickly, before I make my presentation, I want to react to what Wilson, Professor Wilson Mandala, as well as a professor from College of Medicine were commenting in terms of the college, the lockdown case in court, I would put it that way. I was privileged to participate in drafting Society Doctors of Malawi opinion that went to the court. And from my perspective and understanding of that advice to the court, of course, I'm not supposed to speak on issues that are before the court, but the doctors observed that there was no reproductive number, effective reproductive number identification, as therefore, even in medical sense, apart from recognizing the social impact of lockdown, there was no justification to have a lockdown. So probably the court might not give the lockdown, despite on the basis of the reasons that the then Minister of Health did not follow the law according how it was. So as probably introduced by Stuart, I am a fellow for Reprieve based in Malawi, and Reprieve, as introduced, is an international organization, legal charity, and we assist people that are most vulnerable, and that include those that are facing execution due to death penalty, torture, and ill treatment, and those that are denied due process, as well as face fair trial rights. Reprieve in Malawi started working in 2014 when it was in a coalition with other stakeholders in Malawi Sentencing Project. We, through this project, supported people get resentenced after they had received death sentence, but then now we're trying to get them properly sentenced through this project. Following this resentencing project, Reprieve has continued to work in prisons, and we maintain the relationships with other key stakeholders in working with prisons and people in prisons. And prisons are at a risk of being challenged, higher effective or highly exposed to COVID-19. And we continue to work with these clients as well as those that are sentenced to death, and we continue to call for the abolition of the death penalty. So as I was indicating, Malawi's prisons are some of the most overcrowded in the world, at overpopulation of 260%. And we advocating for safe conditions for our clients and everyone else in prison as a key aspect of our work. Therefore, we have been actively engaged on a COVID-19 prevention response in prisons together with other key stakeholders. Through this, we have engaged the Minister of Health, Minister of Homeland Security, Minister of Justice, as well as the prison service itself. And we have also engaged the African Commission on Human and People's Rights, seeking release of vulnerable people. While Malawi has released some people, which is recommendable, but they have not done enough. We have not done enough to fully implement the WHO guidelines. Further, in an effort to separate sections for admissions, the female sections have been taken over, and women in prison have been moved to other locations that are more crowded and further far away from their families. With confirmed cases in most of the prisons across the country, the call for more releases has become extremely urgent. So taking this opportunity, we are hoping that we will engage with all stakeholders, NGOs that are based in Malawi, as well as government stakeholders, in terms of answering some questions to say, what are actions are required, or are we engaging in to ensure that the vulnerable populations in prisons are released or otherwise protected. These populations we include, but not limited to, the elderly and the sick, and especially those with underlying respiratory diseases, and people saving life or death on the death row who are no longer at risk to society. And finally, additionally, we, in light of the ban on prisons visits, we wanted to find out or engage on what measures are being taken or put in place to meet the gap of the dietary needs of prisoners that has been created as a result of the ban to the inmates. So thank you, Stuart, for this great opportunity. And if my colleague I'm with on the call, Sam, has got any other contribution, I thank you for this opportunity. Thank you.
Alexious, thanks very much indeed. I wonder whether you'd like to put a contact as well into the chat function. Again, anybody can get in touch with you through us at the Scotland-Malawi Partnership. There's Susan Flynn saying that she would like to receive information, in fact, on deforestation. So sorry, I've misread that one, Susan, but I'm sure there's lots of people who also want to get in touch with Alexious and Sam. So do feel very welcome to do that through the SMP. We turn now to, again, running slightly behind time, but an opportunity really for anybody to share an update that they would like to with the rest of the group. I wonder perhaps if maybe just 2 or 3 key points of learnings that anybody would like to share, or questions that they would like to seek some support with from others. So there's 55 of us on the call. Who's the brave soul that would like to go first?
If I could jump in here, please.
Please do it. Is that Callum? Sorry,
Yes,
I don't see
Callum
it.
speaking here. Sorry.
Go ahead. Callum Wilson at University of Strathclyde.
Thank you. Yeah, it was really useful to hear the information from everybody who's spoken today, and to be reminded of the ever-present threat. As per the last meeting, I kind of was starting to wonder just how more severe the situation would get in Malawi, and now we definitely see that unfold. So for those who were not aware, I'm a part of a society at Strathclyde called Strathclyde Students for COVID Relief, and we are a group of students who have just aimed to use the skills and expertise we have to help COVID relief efforts. And due to the existing links with Malawi, we targeted Malawi as a place that we can, that our skills could be best used. Just to give an update on our end, Professor Wilson Mandala didn't talk about the innovations at MUST, and instead focused on other aspects. But I would like to say we were very privileged to have a discussion with Professor Wilson Mandala and other members of the design teams at MUST a couple of weeks ago. And we're now in the process of working out where our expertise can fit into the existing projects they have there, and also continuing on with our project of designing a CPAP device that can hopefully be used to treat patients with COVID-19. So again, I'll put my email in the discussion if anybody is interested in this. Our projects can go to many facets, and I would like to discuss this more, but just from ideas I've heard from the meeting so far, I know we have a psychology department at Strathclyde that could be useful for helping deal with the psychology aspects of people on the front line. So please get in touch, and we're very keen to help in any way we can. Thank you.
Callum, thanks for these range of offers. That's great. Thanks, much appreciated. We'll turn now to David Hope-Jones for a summary and key actions. David, over to you.
Thanks very much, Stuart. Friends, this is the 7th in the series of these meetings that we've had since March, and feedback from members suggests that it's useful to, at the end, have a summary of some of the key points that have come up to draw the threads together and to propose a way forwards, and I'm happy to continue to do that. I think probably I, like all of us, look very frequently at the statistics and the numbers coming out from Malawi, and I think probably the one thing more than anything else that I take away from the last 90 minutes is not to draw any complacency at all from the comparatively low numbers that are there in Malawi, with just over 100 reported deaths so far, recognizing the points made from Professor Mallewa and others, that is a very, very significant underestimate. Let me highlight some of the other points that I drew out of Jane Mallewa's talk. It was good to know what the College of Medicine is continuing to do to fight COVID with others, the key role that their testing labs are having, their close working with Queen Elizabeth Central Hospital and their surveillance team. There were, I think, 8 challenges that she identified. Let me summarize them. Firstly, that early in the crisis, there was genuine fear from nurses on the ground, on the front line, and there was an important role to reassure and to train with some clear success. There was a concern that she highlighted about how junior some of the medical staff, given senior responsibilities, were. But again, she reassured that progress had been made on that front. She and others talked about the impact of the 23rd of June election and the campaigning in probably the month running up to it. And anyone that was at our last meeting will remember that it was repeatedly said that this really will cause issues in the coming weeks and months. And I think we're seeing that now in the numbers. Concerns communicated about the levels of PPE that are there, but perhaps most significantly, the numbers of nurses, the lack of nurses. And I think very important that we register this point, that the nurses often are there in country, they are available, and it's about funding and commissioning of those nurses. I think very sobering to hear that testing kits are now very significantly being rationed in Malawi, with them really almost entirely having run out. I'm keen to also register what we've heard about the increasing psychological impact, something obviously healthcare professionals in the UK have experienced as well, the psychological impact for frontline workers and insufficient beds in Malawian hospitals. I was pleased to hear the support that's there from Liverpool Wellcome Trust, the clear success that the oxygen plant in Blantyre has had, the role of charities in supplying PPE and research affiliates in offering other supplies. Perhaps just 2 things I want to pull out of the Q&A that we had with Jane, if I may. The first, the question on attacks on health personnel, I was very reassured to hear, because I had also heard about this, that actually that was something at the beginning of the crisis around April time, and that increased cultural, I suppose, sensitivity to those cultural factors was seeing progress in that direction. But I also want to really highlight the point that she made around the role of civic society in Malawi, and I would extend that to Scotland as well, that simply waiting for government isn't viable. I remind everyone, the government of Malawi has a budget smaller than the borough of Hackney Council. And I think we're all concerned about what's happening in Malawi and what the future holds, and that there is, as she said, a key role for civic society, for churches, for charities, for all sorts of civic institutions at every level, but most especially those embedded at the community level. And it was a very sobering end to her presentation, in which she gave her assessment that the situation would significantly worsen in the months to come, perhaps for the next 12 months or so. Thank you to Professor Mandala from MUST for joining us and echoing, I think, 5 of those points that had come up. Concerns about the campaigning, his views about the lockdown, and I recognize there are different views in this call about the merits and otherwise of a lockdown, recognizing Professor Mallewa was expressing concern, as others have, about livelihoods and the lack of social security protections in Malawi, as perhaps there are in Scotland and elsewhere. Returnees from South Africa, the limited number of testing kits, and again, the limited nurses were the other points that Professor Mandala highlighted. My thanks to Professor Cubie for sharing that good news story. One of the principles of good practice of responding to COVID for NGOs and for funders that we as a community of stakeholders identified was this really important one of continuity of essential healthcare services. So fantastic to have that example from Professor Cubie and colleagues about the continuity of cervical cancer screening across all regions of Malawi. Thank you to Lillian for her presentation on fuel poverty, and to Alexious for quite rightly identifying the issues of vulnerable people in Malawi's, as we all know, overcrowded prisons, and Callum there for the role that the Strathclyde University Group are doing. Since our last meeting, roughly a month ago, we have been busy working with, of course, our members, our partners in Malawi, other key stakeholders, but also Parliament and government. We've had, as many of you were with, a joint meeting of the All-Party Parliamentary Group in Westminster with the Cross-Party Group for Malawi in Holyrood, which included a strong focus on COVID and highlighted a number of the topics that have come out from these series of now 7 calls. Stuart and I met with the head of DFID Malawi just earlier on this week, Dave Beer, and had a couple of hours of sharing information and intelligence about COVID and other things. And again, a good opportunity for us to raise and discuss the points that are coming out in these calls. And I met last week with the new Secretary of State for Scotland, and again was able to raise our members and our partners' strong concerns about COVID in Malawi. Looking forwards, I'm aware that over the next month, certainly Scotland and possibly Malawi will have schools reopening. And I think there are shared challenges and great potential for a sharing of learning and viewpoints between Scotland and Malawi as that moment is reached. It's something we were discussing with DFID Malawi earlier on this week. The new Education Minister is a long-standing friend of the Scotland-Malawi Partnership and MASP. She's been a long-standing MASP member and sat on the MASP board. So I've invited the new Education Minister to join a digital meeting looking specifically at educational links between Scotland and Malawi, for which COVID and the schools reopening will be a key point of discussion. So I look forward to sharing details of the date and time of that meeting once we have it. I think it's crucial that in Malawi, if schools are reopening, that parents, pupils and teachers' confidence is built that it is safe and appropriate to do so. And I do think that there is useful sharing between our 2 countries on that. Depending on the scheduling of that meeting, we'll look to have the next in this series, the 8th of our general COVID meetings, around a month's time, most likely towards the end of August. I remind everyone on the call that we were highlighting more than a dozen different fundraising appeals from members. I recognize the success that Classrooms for Malawi, one of those appeals, has had. And they had a parliamentary motion in Holyrood the week before last celebrating that success. But I think I also want to register the hospital fund that Dr. Mallewa highlighted. I think everyone on this call will be keen to support how they can, that call to employ nurses that are already in Malawi. What could be more sensible and what could be more urgent? So our priority in the next month will be finding out more about that appeal and raising awareness through social media and through the bulletin. And we encourage everyone on this call to consider how they could support, amplify that ask, and perhaps donate themselves. We'll continue to promote the principles of good practice agreed by this group with NGOs, our members, and with funders. We encourage everyone to continue to share their own perspectives in Scotland and their partners' perspectives on COVID with us. I see that Mike Beresford from the Zambezi Trust, one of our members, has just put on the Slack group a new video from his partners in Malawi. Please do continue to share that. If you're not a member of the Slack group, please do join it. It's the best way of sharing what you're doing and making connections between meetings. Our bulletin, our weekly bulletin that goes out to all members, will continue to have the numbers of COVID cases in both Scotland and Malawi and all key relevant updates. And our web hub, if you go to Scotland-Malawi Partnership /COVID-19, you will find all information. I suppose the final point I want to make is just to highlight our current plan is that our AGM, the Scotland-Malawi Partnerships AGM, will take place on Saturday, the 3rd of October, either entirely digital or hybrid between digital with elements of in-person. A key part of that will be a retrospective of what we've done so far on COVID and planning going forwards. We will invite the new president of Malawi as the honorary co-patron of the Scotland-Malawi Partnership to take part in that meeting if he is able to. And I think that would be an appropriate place for us to formally communicate Scotland's continuing concern and thoughts for our friends in Malawi and a strong willingness to continue that spirit of cooperation that we've seen since March as both of our countries go through the COVID-19 crisis. Please do continue to tell me and my colleagues what you want us to do for you to support your work and cooperation between Scotland and Malawi in this next period. The chapter is potentially changing and we recognise our services should change in response to that. We are your network and please do tell us what you want us to do. In closing, let me thank Stuart for doing, as he always does, the most amazing job in chairing these meetings. I can now see him, he's popped up and he'll be blushing, I'm sure. Thank you to our speakers, particularly to Professor Mallewa and Professor Mandala, but thank you to everyone. 7 meetings in and we're still getting 60 organisations taking part an excellent caliber of discussion. My thanks to all of you. Stuart, back to you.
Thanks very much, David. Just 2 or 3 final points, if I may. We are keen to test appetite amongst members for even more informal, even shorter chats. You'll see the screen that Craig's shared there on virtual coffee break catch-ups. And just if that appeals to you at all, to share your experiences with one another, to touch on topics that we haven't been covering so far, then do let us know if that appeals, please. Craig will also kindly share a very, very brief survey form in which you can instantly give feedback on this meeting with just, it's appeared now, with just 3 questions, rating the meeting, whether it's strengthened your Malawi connections, and then the frequency with which you'd like us to hold the meetings. We do get a range of responses there, but do please let us know whether you'd like the next one to be in 2, 3, 4, or 5 weeks. So really just to thank you for being with us again on the 7th meeting, and to thank all of our speakers very much indeed, particularly, as David says, to Professor Jane Mallewa for joining us today. If you've had a chance to click on the feedback survey, I wonder if I could ask you to kindly put your video on so that we can have an array of faces and see who's there, and we'll do a screen grab, which we'll share at some point in our bulletin and our social media. I see lots of you doing that. Thanks very much. Give us a wave, that'd be great.
Bye.
Thank you. Well, thanks so much for now. Take care, and we'll be in touch. And we always value hearing any feedback from you. So please let us know anytime. Thanks very much. Take care. Bye-bye.
Thank you, Stuart. Bye-bye.
Thank you, Stuart.
Thank you.
Thank you. Bye.
Bye.
Thank you. Bye-bye.
Bye, everyone.
Thank you. Very interesting.
Thank you. It was nice.
Thank you. Bye-bye. The education. Bana Julie.